Okay, welcome everyone. We are now live for our second out of 3 Governor Master Plan for Aging Long-Term Support and Services Subcommittee meetings about the long-term care at home benefit. I'd just like to make a friendly reminder to all of our panelists, you are able to mute and unmute yourself, so please keep yourself muted while you are not speaking. Go ahead and advance the slide, please. Today's meeting is available by webinar and phone only. And closed captioning is available. You can access that using that CC button at the bottom of your screen. All of today's meeting materials will be posted to both the Master Plan for Aging and DHCS's web pages, including the recordings. Next slide, please. And we do have time reserved at the end of this meeting for public comment. We'll go ahead and share these instructions with you at that time. And I do want to let you know that we have 2 email addresses where you can submit comments or feedback on the meeting. One is ltcathome@dhcs.ca.gov. And for Master Plan for Aging public comments, you can send those emails to our engage@aging.ca.gov email inbox. And with that, I'm going to go ahead and hand it off to California Department of Aging Director Kim McCoy-Wade.
Thank you so much. I will offer a few brief words of welcome and then turn it over to my colleagues at DHCS. We want to welcome you back and thank you so much, the 225 of you and climbing who are here on this Friday afternoon to address this issue. You see we've extended the meeting to 2 hours and we've extended the stakeholders, doubled them to almost 40 because we so much have heard that there's more listening and discussion and conversation to be had. We want to make sure we have time to affirm and discuss our values and our vision around access, around equity, around choices for all Californians. We want to be sure that we have the time to have the discussion, to listen, to learn from our history, to look forward to a bold future. And we also want to get to specifics. We know that people have wanted more specifics and more details. Thank you for your input to that and your patience with us as we're all juggling so much professionally and personally right now. I particularly want to thank my colleagues at DHCS for tremendous work on new documents that are now posted in multiple places as of today. The DHCS Long-Term Care at Home page, as well as the Agency Master Plan LTSS Subcommittee page. So let us know if you're not seeing those documents, but that will be helpful to you today as we hear from DHCS very briefly with an update on all their tremendous work with sister departments. And then here, I understand very briefly from the LTSS subcommittee with updates from 2 of their leaders. And then we really will open it up to the new voices from the invited stakeholders, as well as the entire group, and of course have time for public comment. I'm hearing from a few people who we're hoping to hear from who are not yet in. So let me check and see if Will Lightbourne has made it in. Director Lightbourne, are you with us? Aha, not yet. JC, I think I'm going to hand the torch to you and let you take it, and we'll continue to assist and hope to hear from Director Lightbourne as soon as he's with us.
All right. Well, thank you so much, Kim, and happy Friday to everybody. Nothing like a 2-hour meeting at the end of a Friday to roll into the weekend. So appreciate everybody's time and attention on such an important matter today. First and foremost, I apologize I wasn't able to be at the last meeting. I'm very happy to be here with you today and engage in the conversation and hear feedback from so many of you on this important topic. As Kim mentioned, we have issued a revised benefit design document. It just went out this morning, so understandable if many of you have not had a chance to review it. I will at a high level kind of highlight some of the things that have been added to the document as I do a general overview for all of you. We also issued a continuum document highlighting the Medi-Cal home and community-based services, various continuum services across that. And so that has also been posted on multiple websites, both DHCS's as well as the Master Plan on Aging websites. And so hopefully people have had a chance to at least glance at those. I also wanted to extend the department's appreciation on all the ad hoc meetings. We have had over a dozen, if not more, I think probably getting close to maybe 24 at this point, meetings or conversations with people on this topic. It shows the importance of the topic that we are having, as well as all of you who are providing such great input into the design of this policy work as we move forward. The department is also engaging with other states who have similar or this model in place, so we can learn from them and see what that model looked like and those successes, so it can inform future discussions with this group and inform our policy as we move forward. So I'm going to dig into some updates along the way, and then we'll be able to turn it over to the LTSS subcommittee for their update as well. But wanted to kind of just touch base. You know, the intent behind the long-term care at home really is about providing an additional kind of home and community-based service along the continuum of services for individuals needing both medical as well as assistance with activities of daily living in their home. So we really see this as an additional option and a choice for beneficiaries along that continuum. We think, you know, one of the largest advantages of the long-term care at home is reducing some of the barriers that can exist with some of our HCS programs, where there are separate enrollment processes. Sometimes there are wait lists or a lack of statewide-ness. They're only in certain regions of our state. And in some instances, but not all, some kind of complicated federal requirements that can be both for the beneficiaries as well as for the provider. And to kind of, we truly feel like some of those are based on historical federal regulations in our 1915C waivers that I know many of you are very familiar with. One of the questions that we have been getting overall is kind of why a 1959 waiver, and it really speaks to that last point that I mentioned, where, you know, long-term care at home would be a Medi-Cal state benefit by doing it in 1959, which means no separate enrollment and no wait lists, and it would be available statewide. So I think, you know, those are really kind of important things to kind of keep in perspective as we're talking through the benefits of long-term care at home and the option that we're exploring. Given that, I wanted to start before we get into some of the nitty-gritty slides to give background, and we will touch on those lightly. We're hoping that you know, the LTSS subcommittee has really dug into this. We have some new stakeholders with us today, and we know many of you have been engaging in these conversations outside of this meeting and or have read our document, because many of you we have talked to in one way, shape, or form. So I don't want to spend too much time on that, but wanted to kind of give an example of someone who could be receiving long-term care services at home, just to kind of frame it for people. Sometimes I think that's helpful to kind of see it in that perspective. So we have Jane Doe, for example, who's maybe receiving some IHSS services in her home and has frequent visits for various medical appointments, therapy services, etc. And eventually Jane starts also going to a CBAS center in the day, where she's getting great coordinated care, really enjoying her time at the CBAS center. But over time, Jane's health continues to decline. And there's a decision that needs to be made by the family. And the decision is whether Jane should be put into a skilled nursing facility, or maybe if she could get additional services in the home so that she could safely reside in the home with her family. And the decision there is made that Jane would move into her daughter's home and transition to the long-term care at home benefit, where she continues to get IHSS services, but she also is getting long-term care at home services. And Jane remains in those services for, you know, 2 years. And as her health continues to decline, the treating physician recommends that Jane transition to hospice. So this is just an example, a quick example of how we want to start talking about long-term care at home along the continuum of home and community-based services. One of the biggest things that we tried to update in this revised document that we posted is the interplay between this benefit and other existing home and community-based services, or LTSS services, and medical services. When this service may be utilized versus other services, And long-term care at home may not always be the best option for a beneficiary or for a patient. That is what we would be relying on, our clinical partners, physicians, treating physicians, primary care provider, et cetera, to assess and make some of those determinations. But we just really wanted to start talking about it, and you'll see more resource documents from us trying to help put that into perspective across the continuum. The other thing that highlights is, given the example that I just gave you, we really wanted to, and this was really based off of the feedback from the last committee, as well as all the letters and ad hoc meetings that we have received, that we really wanted to step back and take your feedback regarding some of the licensing that we had put forward. And so we really think we will be able to leverage some of the existing providers in the HCBS space today to become long-term care at home providers. So we're working very closely with our partners at Public Health to look at the various existing licensing opportunities and to see what types of providers would be good long-term care providers within existing frameworks, where the department could then certify existing providers to meet the requirements of the long-term care at home to provide that benefit. We think there are good examples with home health agencies, our CCT providers, case organizations, even hospice and hospital, hospice agencies and hospitals themselves. All are good examples of providers, not an exhaustive list, of course, just a list I just rattled off, that could, potentially convert their model to kind of meet the need of this long-term care at home model. So we really just wanted to kind of frame that in a larger kind of picture for people based on some of the feedback that we've gotten, just to kind of make sure people are kind of tracking those interactions and the evolving policy that we've been working on. And so I think now we can kind of go in. I know someone else is probably dictating the slides.
Yeah, and Jason, let's pause for a second, because I do think
Sure.
we managed to get Director Lightbourne in and
Yes.
see, I think. Will, are you able to hear and to speak?
Yes, indeed. I'm sorry that I was technologically challenged, but thank you, and I'm here.
Would you like to make any opening remarks?
No, I mean, I think JC has basically covered it. I mean, I think the key to us is seeing this as part of the continuum of care, leveraging the existing parts of the continuum of care, and really sort of bringing together and coordinating in a way that has probably been missing in the past. So with that, let me leave it in JC's hands.
Excellent.
Great. All right. So we wanted to kind of, if we can go to the next slide, because I think Kim already walked through that piece. There we go. So we wanted to kind of frame it up in that context. I think because of, it will reflect some of the edits that we have in our revised document. I would just note, with our revised benefit proposal, we could not get to all of the edits yet. A lot of feedback, a lot of things we're still considering. So this is the next version, but it will continue to evolve. And a lot of the pieces that I tried to open up with is we're trying to think through how we describe the benefit a little bit differently to people, to kind of put it in that context around the continuum and around leveraging all of the great expertise that already exists out there and building on that. So as a quick recap, I think I've gone through most of these already on this slide, so we can probably go to the next one. It's really about identifying additional choices for beneficiaries to receive both medical and activities of daily living, social services, or related HCBS services in their home, and that would include individuals. And the one piece that we will have more detail in the next version is around eligibility. We are hearing your feedback, and so, but the higher context is somebody who is in a skilled nursing facility who would be able to transition to their home would be eligible for this. Somebody who is in a hospital being discharged for a short-term stay would be eligible for this. And then to avoid skilled nursing facility stays where someone is not yet in a skilled nursing facility or institutional stays, and to avoid that. So the benefit is a little bit broader. Sometimes that can make it a little bit hard in the context of how we've talked about some HCBS services before, because that short-term skilled nursing facility stay is slightly different. And so we're still kind of working through some of that with stakeholders just so they understand. And one of the things we'll have to have for the submission to CMS is a well-defined eligibility category. One of the things that we did in the interim in the document to give some context to you is just provide a case study or two under each of those eligibility categories, so you could get a flavor for who we're talking about. But there's still lots of work to be done in regards to the actual eligibility parameters. Next slide. Yeah, thanks. And so I think the other thing that we have heard some feedback on, and just wanted to kind of re-emphasize here, and I'm sure my team emphasized this at the previous meeting, is, long-term care at home really came out of some of the early kind of COVID-19 discussions. We were in the process of looking at, decompressing hospitals, decompressing skilled nursing facilities, and one of the ideas that was being discussed is hospital at home. And so it converted quickly to skilled nursing facility or long-term care at home. It is something that we continue to talk about today. And I know both timelines have been discussed, as well as kind of the decompression of skilled nursing facilities. Thank you so much for the letter from the LTSS subcommittee, and we know you guys will get to that later. But it really speaks to one of the items here in regards to how this all came about. And it really came about in the early months, March and April and May, discussing options for how to decompress skilled nursing facilities. We continue to have those thoughts. It's one of the biggest things driving the timeline. You'll see this reflected in our document. We know that we need to engage in stakeholder feedback. We are committed to that. We're committed to engaging with the legislature, and we want it to be built right. And we will continue to do that even after these first few meetings, hopefully though with the future in line of really moving forward with a state plan amendment to move this forward, because we do think it gives options to people for all the transitions that we've talked about and the ones listed in our document as well. Next slide. Okay, so I think we've talked about these. Sorry, these slides are a little just for background and recap. Next slide. Okay, so this was really the main update that we wanted to give everyone today. So there's a few pieces that we wanted to kind of highlight that are new in our document and kind of walk through everybody at a high level. The first one I kind of mentioned in my introduction around provider licensing requirements. So one of the biggest revisions that you'll see in the new document is around the licensure requirements. The original proposal and what you would see in our trailer bill, the original thinking was to have a separate and new licensing requirement for long-term care at home. Based on extensive feedback that we got from many of you, we have pivoted based on that feedback to really leverage, as I mentioned at the beginning, existing licensure categories and providers that we would then certify to meet the long-term care at home requirement. They would have to be enrolled Medi-Cal providers, of course, and then in fee-for-service, they would be able to provide those services once enrolled, and in a managed care plan, they would still have to be a contracted provider to provide the long-term care at home benefit. So you have that will be reflected in the updated document, and we tried to include some examples. Oops, we just lost our slides. They're back. We tried to use some examples in that document. I mentioned some at the beginning of this meeting. That's really just to kind of move the conversation in regards to the types of providers that would be most likely able to convert their existing model or to expand their model. Just to be clear, for example, a PACE organization. They are providing PACE services, and as you see in our document, you can't necessarily be getting long-term care at home and also be in a PACE plan, but a PACE organization may be a prime provider then to offer a subsequent line of service for long-term care at home. That's just one example, for people to think about this a little bit differently as we try to utilize subject matter expertise and providers who have that expertise out there to think about this model a little bit differently and be able to maybe convert their model for a piece of their line of business to be focused in this area. The other piece that you will see updated in our document is we tried to outline some of the interactions with like programs. That's why we put together the continuum document so people can start seeing the interaction across services. We highlighted in the revised proposal when you would use a home health service, for example, versus a hospice service versus long-term care at home, and then where you can't be enrolled in multiple projects. So you or programs, you can't be in a 1915C, for example, the home and community-based alternative waiver, and also be in long-term care at home. So we've highlighted that in the document. Hopefully that became clear, open to feedback from people on that. Many of those are federal requirements and rules that we won't be able to get around much, but we did try to make that clear so that reduce that confusion. We also updated the Medicare interaction. So we got, based on our first document, there seemed to be some confusion around whether we were committed to duals in this process. And we do want long-term care at home to be available for duals and for our Medi individuals. However, we know that that's also a complicated policy area that we are still digging into. So we are looking at all the different types of interactions that would trigger, how this would work. We are partnering with CMS on that. I think one thing to just highlight for people is CMS is also very interested in what we're doing here, and I think they will be a good partner with us as we explore the interaction for our dual beneficiaries in this program. We also heard a lot of feedback from people around health equity and in long-term care at home. And as Kim talked about in her opening introduction, really something we want to hear from people. How do we ensure that this program is equitable across our populations and is going to meet the need of low-income individuals, which is dominantly who Medi-Cal serves. And so we are exploring, we've got some feedback around opportunities for bringing this not just in quote unquote homes, but assisted living areas, RCFEs and ARFs for the additional services. And we've gotten a lot of comments in that place. It's not reflected in our current document, but we are doing some serious thinking in that area. How could that work? What does that mean? What does that interact with? And so we did wanted to highlight that for you, that it is something we are putting thought into, because we want to make sure that individuals who don't have housing options today still have the potential to utilize transitions home like others who have the ability to have a home. So something we're seriously thinking about, just not reflected currently in our revised document. And then last but not least, and I kind of touched on it earlier, the timeline. So you will see here, and what we would say is that we're committed to continuing engagement with all of you through this process. We want it to be right. We want to make sure the policy is built correctly and engage with you in the legislature through the process. What that timeline is, I think I kind of tried to emphasize with the momentum right now that we have with CMS and with many, especially with the need around our response to the public health emergency. We still would like to move maybe a little faster than we normally do, while still staying very committed to engaging all of you through a feedback and stakeholder engagement process to build it right. Next slide. Okay, so those were the main updates I wanted to hit. Let me just pause. Kim or Will, anything else you want to add in regards to recaps? I didn't do too much of the walk through the document because so many people have seen it for so long. I don't want that to be the focus. More focused on clarifying pieces that have been raised to us, questions, and then also highlighting some of the updates to the document. Let me do one more before you answer that question. The other update that we had, or questions we've gotten around transition services, we try to make it really clear in the updated document that transition services are paid separate and apart than the per diem for long-term care at home. Transition services would probably be provided by a different provider than the LTC at home too. There may be some qualified LTC providers who could do both. They would be billed separately though, but in the transition services is really about finding the placement for the individual, transitioning the person home modifications needed. And there's not very many people who can do that or do that well. And so we really want subject matter expertise doing that, not just someone who's coming into this blindly. And so those would be separate kind of eligibility criteria, potentially separate providers, and they would be paid for separately. We've gotten a lot of questions on that. So just wanted to clarify that. We try to clarify it in the document. So Tim or Will, anything else you would like to add?
For my part, no. I mean, I think you covered it well, and let's leave as much time as possible for the group conversation.
Will said what I was going to say. So I think we will. I just want to acknowledge how much work has gone in and thank my DHCS colleagues, particularly JC and her team. There was a concept paper a few weeks ago. There was great addition to get to the design paper about 3 weeks ago, and now we can see another progression forward in dialogue and detail, and so that will continue. That cycle will continue. So thank you for all the hard work and for everybody here, but particularly for JC and the team the last couple weeks. We do want to open it to the committee members and invited stakeholders. I'm going to ask for your indulgence here. We're going to do Amanda Lawrence, our project director, is going to do roll call. We have an incredible lineup of about 40 esteemed people. So just take a breath and listen to the amazing colleagues who are here with you as Amanda does roll call. Thank you.
Okay, so what I'm going to do is start with the long-term support services subcommittee members, and then I'll move on to the additional stakeholders. So go ahead and you can just say here if you're here. And if you are on the phone and we don't have your number yet, please hit *9 to let us know that you're on the line, and we can then move you over to the panelist list. So I have Anna Acton.
Here.
Maya Altman.
Here.
Catherine Blakemore.
Here.
Catherine Barger. Christina. Okay. Catherine, is that, do we have a 3830 number? Could we unmute and could we have? Great.
This is, hello, this is Nina Weidel Harwell on the 3830 number.
Okay, great. Thank you, Nina. Christina Bass Hamilton.
Hi, I'm here.
Great. Patty Berg. Donna Benton.
Here.
Craig Cornett.
Here.
Susan DeMorris.
Here.
Karen Feiss.
Here.
Julia Figueroa McDonough.
Here.
Karen Kiesler. Marty Lynch.
Here.
Peter Mendoza.
Here.
Lydia Miselides.
Present.
Marty Yamoto.
Here.
Claire Ramsey.
Here.
Ellen Schmeeding.
Here.
Sarah Steenhausen.
Here.
Jeff Tom.
Here.
Brandy Wolf. Okay, those are LTSS subcommittee members, and I'm going to move on to our additional stakeholders. Sheila Clark. Dean Chalios.
Here.
Linda Nui.
Linda Way, he's here.
Brianna Learman.
Here.
Amber Kemp.
Here.
Kristen Hemmon.
Here.
Janet Heath.
Here.
Ann Kinderman.
Here.
June Simmons. Kim Lewis.
Here.
Pat Blaisdell.
Here.
And Jeannie Parker Martin.
Here.
Pauline Shatara.
Here.
And Anita Friedman. I believe she's unable. Matthew Diaz. No hands. Denise Leicar?
Present.
Oh, Matt Diaz, I see you. Could we move Matt over? Dr. Aquino. I saw Dr. Aquino.
Here.
And Dr. Lincoln, Dr. Karen Lincoln.
Present.
Great. And Ricardo Torres. I did see Ricardo. So we'll get you moved over if you're in the phone section. That is everybody. Thank you.
Thank you all. So with that, we'd like to turn to discussion. I understand from the committee that they have an update as well that will begin with Anna Acton. Anna is, in addition to being a member of the committee, is the executive director of FREED, the Independent Living Center in Nevada County, serving multiple counties, and a core partner with CVA on the Aging Disability Resource Connection. So Anna, I'll hand it off to you.
Thank you so much, Kim, and thank you, JC and Department of Healthcare Services. So I'm just going to start us off here and remind us that this is all about the people, right? It's all about the individuals in the community, and that systems must be designed around people. The LTSS subcommittee believes that meaningful change can only be brought about by addressing the needs of the whole person. This means providing coordinated access to medical care and related therapies, but the critical home and community-based services that people need to live with dignity and independence. In this time of COVID, right, we're living in a very interesting time right now. We feel it's important to highlight 3 stories of real people that I want to share with you who have been impacted by COVID and who have relied on home and community-based services to transition to the community or remain in their homes. Any meaningful systems change cannot be do away with the home and community-based infrastructure, but must instead build upon and innovate it to meet our most urgent needs now. So the 3 stories that I'm going to share with you today really kind of highlight some core principles. We cannot address this crisis with a medical model. We have to rely on strong foundations of home and community-based services, and especially housing. We keep on hearing this time and time again about housing being a critical piece. We must rely on providers who are experienced and knowledgeable of these services and supports that this population needs. And any benefit must rely on coordinated, integrated care with flexibility to design care plans that meet consumers' individual needs. We also know that it will take time and resources for us to do it right. And we also cannot forget through this process that we have to focus on providing a high quality workforce, which means paying better wages for our critical care providers. So I also just want to mention that, you know, COVID is really exacerbating a lot of issues that have existed before, and are really, the transition piece is really critical during this time for people. So the first story I want to share with you is really highlighting, it's a nursing home transition to home to really help support quality of life at the end of life. So during COVID, Sally went to a skilled nursing facility to recover from a stroke. She received rehab and then hospice care. And in the current environment with COVID, there was no direct support of loved ones. The consumer was alone without support for decisions about care and changes in treatment plan, without trusted eyes of quality of care. The joy and incentives that the world outside of medical care offers was missing for her. All information was loaded towards the medical model tailored to insurance coverage and the needs of an efficiently run nursing home. Her spouse was in a state of not knowing, waiting by a window to see if they would even bring her that day. He could not support her decision process, was not informed of changes in treatment plans, and did not interact with her day-to-day caregivers, and had difficulty connecting with someone at the nursing home for information. The consumer became depressed and her progress stalled. She was lonely and disconnected from her life. There was no doubt that this consumer knew she would not live to recover from her stroke, but it was clear she wanted to spend her remaining time in the home she loved in the comfort of her life's accumulation, surrounded by people who shared love with her. Along with home health and hospice, we were able to support this consumer safe transition. We worked with the consumer, her husband, the facility to identify her needs and access existing funding and community services and supports, including assistive technology, hospital beds, rolling shower chairs, Hoyer lift. Home modifications had to be done quickly. We tapped into Department of Rehabilitation's transition grant that provided funding for initial medical supplies, home setup, a manual wheelchair, and most importantly, transitional in-home personal care to support her. It took extensive service coordination, pre and post-transition, including assessing her needs, developing a person-centered plan, identifying community-based services, and supporting options and supports, and supporting her to navigate through all this for the first time. She was able to transition home, and within a couple of weeks, she passed away in her home with appropriate care and support, surrounded by those who loved her and she loved. And that is a story of someone that we've worked with and is actually a neighbor of mine as well. The second story that I wanted to share with you is someone who's at risk of long-term institutionalization. Laura has been a Freed consumer for years. She is someone that we have transitioned using the California Community Transition Program. She's been living in her community, interacting, engaged in advisory committees, very wonderful advocate in our community since she's transitioned there. But during the month of May and COVID, things really changed for her, and it made it very difficult for us to support her. Her care providers started to dwindle. With very minimal support, she started struggling with her activities of daily living. Laura contacted IHSS, and they told her that because of COVID-19 restrictions, they were not currently bringing on new providers, and they had no new providers to refer to her at the time. Finally, in June, her main support staff had to quit due to a family emergency and related to COVID. When that happened, existing providers were unable to meet her hours, and she ended up just going to a hospital out of desperation to try to get support. There was a systemic shortage of care providers available through IHSS and even through private pay. This was extremely distressing, and she ended up back in a nursing home just to get her personal care needs met during this time. Laura was struggling with isolation while she was in her home because of COVID. And then found once she got into the nursing home, that isolation was intensified for her. There was intense coordination efforts among various agencies to transition her back to the community before she would lose her housing, making a whole new problem for her. So at the beginning of July, we were able to assist her in interviewing 4 care providers while she was in the nursing home, which she hired, and then we were able to return her back to the community and into her apartment. The third story is a story around long-term nursing home transition and trying to get people who've been in there for a while to back into the community. So Anne's been in this nursing home for a few years. She's been ready to live independently for some time, but she has no relatives or friends who can help with the process. Freed has been assisting Anne in getting Section 8 voucher, which she finally has, and arranging to get a certified birth certificate for documentation needed by the Regional Housing Authority. Due to COVID, she cannot leave the nursing home without having to spend 14 days in quarantine upon her return. So Anne and Freed have been working to secure permission from the SNF for a mobile notary facility. The process has slowed down her ability to considerably for her to get her birth certificate. And then securing housing is also going to be adversely affected by COVID-19 due to the quarantine. Freed staff are developing systems so that available apartments can be viewed by a staff member, a volunteer, pictures can be taken and sent to Anne, and then if the landlord has not already accepted that Section 8 voucher in the past, working with that landlord to accept that voucher for her. So that story is still outstanding. We're not sure how it's going to end for her. We're still continuing to support her and her efforts to live independently. So I know that was a lot of time. But I think these are really important stories to tell and to make sure we're rooting our conversations and systems change in the people who are affected by this. So I want to thank you for the opportunity to begin the discussion focused on what matters most, the people, and not forgetting the roles that critical home and community-based services play in meeting the population's needs. We look forward to an engaged discussion, and I know I will ask that my colleague, Catherine Blakemore, provide the LTSS subcommittee statement.
Thanks so much, Anna, and for sharing sharing those stories, which to me is always important and powerful, because it's why I think everyone on this call does the work that we all do. So those were compelling and sometimes a little hard to hear, just the pain that people go through. I also want to thank the Department of Healthcare Services staff for the work that you've done. And for and some of the framing that you did today. And from that, I want to just start by reflecting for a moment before I go into our position statement on what I really think are now a set of some shared values that will help us as we're going forward. And the things I heard that are shared is, one, JC gave an example in addition to Anna's, which says we really should focus on the people that are involved. Will spoke to the importance of leveraging existing resources. I think JC talked then about we want to do it right, and that there's also an interest in, we need to address the immediate need and crisis that we're in and ensure the system is equitable. So I think those provide a really good common foundation for us as we're going forward, and certainly things that have been on the mind of the Long-Term Services and Support Subcommittee as we begin to think of a way to approach the many facets of the proposal and the current crisis that we're in. So I want to speak just for a few moments to that. I think you all were sent a copy of our very short sort of statement today that you can read in its entirety. But we really believe that what we need to do as we're thinking about this long-term care at home benefit is do two things. We need to look at the immediate crisis response, because we are, we spoke about how April and May, this was discussed as something that needed to happen to help people move from long-term care facilities or to avoid placement in a long-term care facility. But if one looks at the data today, we are really back to where we were. I mean, we have better hospital capacity, but we're back to where we were in terms of the rise of COVID. And that means that we need to focus energy and time on what can we do now as we're developing other proposals. And I'm going to talk a little more about that crisis response. And then the second piece is planning for a meaningful long-term care benefit. So for us, the immediate crisis response really means an opportunity to step back and say, how can we leverage existing resources and additional federal flexibility that the federal government has allowed states to do, to look at ways that very quickly we can help people move from nursing facilities, other care facilities, back to their home with the appropriate kinds of supports. I think it is also the opportunity in this period of time to think about the existing providers of services and figure out how they can have increased flexibility to provide some of the very things that we're talking about as part of this long-term care benefit. So it will help not only address the immediate crisis, but also help inform what we can do in terms of moving forward as we're looking for providers that will be able to offer that long-term care at home benefit. We, like the state, put together a chart that is somewhat remarkably similar to here's what currently exists and here's where the overlaps are. And we're going to develop that further into, if you look at people who need to move from hospital to home, who could coordinate that care, who could provide that services. That's our next step. Someone who's in a skilled nursing facility, who has needs that can be met at home, who could currently provide those services, and what would that look like, and how would that care be coordinated. And our commitment is to finish that work by the end of July and have a proposal for the next stakeholder meeting where we can talk about what can we do now. I think for us, the crisis remains in front of us. We all know that people in nursing homes die at higher rates than other people. And we also know of the devastating impact that those deaths have on Black and Brown communities. And it really is incumbent upon all of us to work hard to address that immediate crisis. The second part with a different subcommittee of LTSS is to look at what does a meaningful long-term care benefit at home look like? What are the components of it that have to be included in it? I'm grateful for the additional work that the state has done. I think there's more opportunities for us to talk about not only the principles that should guide that, but also some of the specifics and the scope of benefits, medical as well as home and community-based services that should be available for that. And again, we're going to do that work by the end of July to present at an upcoming meeting. So those are the two components that the Long-Term Services and Support Committee is working on. I think they fit nicely with the work that the state is doing, but maybe provide some more immediate steps that can be taken, particularly on the crisis side. And we look forward to continuing to work with all of you.
Thank you, Anna and Catherine. And thank you also for grounding us in the people and the values and in collaborating with us all the way through. I want to thank everybody for moving quickly to create time and space for the invited stakeholders to provide content. So I'm going to let Maria, our technology facilitator extraordinaire, explain how that's going to work. And we're going to change the screen a little bit and start raising hands so that we can open up this discussion for all the stakeholders who are here today. We've got about 45 minutes or so, and then we'll open it up for public comment and do a very brief wrap.
Thank you, Kim, and thank you, stakeholders. I think if you have a comment or question, just go ahead and toggle your hand. You can use the raise hand feature on your toolbar, and that will add you to the queue. If you are a stakeholder who is dialing in by phone, I think we have a couple. You will want to hit *9, and that will raise your hand. And again, we can unmute your line. So first up, it looks like we've got Ellen. Ellen, you can unmute yourself and go ahead.
Okay, great. Thank you so much. Very invigorating. And I did have a chance to read the update, and I am highly impressed by this chart. I am not easily impressed by charts. I think this is something that's very valuable. My question is, how many people are we talking about for this program? Do you have any sense of the size of the population that can be served? And then how will you measure success? How will you know that the program is successful?
So we are still running data in regards to the size and the numbers, and we will need to do that for financial modeling and various pieces. So we're still doing some data mining. So I don't have a number for you today, but in the future, happy to have those conversations with people. And then, measuring success is a great, it's a great flag for us, right? We've kind of been heads down thinking about the policy, but kind of have to always build that in light of the outcomes and the principles that we want to achieve. I think for us, quality care is important, as well as, health outcomes, people being able to safely reside in their home, and a number of other pieces. We have multiple 1915C waivers where we look at a myriad of outcomes that we report to CMS at any given time, but they don't always reflect maybe what we're actually trying to see as outcomes. And so I think we're still doing some thinking on that, but open to any thoughts, comments from so many subject matter experts to be able to bring in those ideas as we start continuing to build this program over time.
And I'll just briefly add on the outcome piece. Of course, the master plan will have data dashboard with outcomes, including independent living, health and well-being. And so this would be one of the drivers potentially of that continued expansion of living at home with those wellness and outcome and well-being and equity outcomes that we're seeking.
Thank you very much. Amber Kemp, you're up next.
Hi, thank you so much for including the California Association of Health Plans in this really important discussion. Plans are really critical partners in the administration of this benefit, and really look forward to partnering with the Department of Healthcare Services and the many other stakeholders included in today's discussion to ensure that this benefit is operationalized to really improve the healthcare of Medi-Cal members and to support the department's vision that it has in operationalizing this benefit. So thank you so much for including us as part of this discussion, and we look forward to working closely with all of you over the next weeks and months. Thank you.
Thank you, Amber. Marty Yamamoto.
Hey, thank you. Marty Yamamoto, family member, California Disability Senior Community Action Network. And also Will, I don't know if Will's on the line, but I just want to say welcome back. You never disappear too long, so it's good to have you. So,
Thanks, Marty.
Number one, if Kim or someone could, after I finish my questions, just, or maybe JC actually, for the benefit of those listening who are not on the committee, just explain what decompression means, because that's not a term that normal people use unless they're, part of this group. And that's a key term, for all of us to understand. And just to follow up on what Ellen, your question about how many people, and I think that is a good question. And also where are they coming from? And, how are they touching or not touching communities of color when we talk about issues of equity? So that's going to be important. I know that JC, or was it Kim, said that you're working on that information. And to follow up on the outcomes issue is to making sure that we're just not measuring utilization, which has historically been the measurement. And Kim, I think you're referencing again the other tools that we had talked about, so that would be good. In the other states, JC, you mentioned the other states have tried this model, or other states were going to try this model. And it'd be interesting to know what states those were and where are they in terms of, moving forward on this, and, what's the successes that they've achieved, because that'd be good for us to know that too. And lastly, two more points is on the Department of Developmental Services, because I know this benefit, could impact people with developmental services or developmental disabilities, like my older sister, if she was still alive. How much have they been engaged working with you? Because there are some barriers and issues that need to be dealt with in terms of the regional centers. There's a provider network that actually could be a useful, tool in terms of accessing those providers as a potential network of providers. And lastly, Catherine, to follow up Catherine's point on the issue of emergency response the response to the emergency that we're facing now. And that, just to underscore that, we all feel that we do nothing that undermines our ability to respond in the coming months and the coming year. And also just want to thank you, JC, and your team and everybody else, all of us actually, for working together on this to try to find solutions. Thank you. Oh, and so there were some questions in there actually too.
There were quite a few questions in there. I will try to hit them. I was typing a few as we went, just to make sure I could try to touch on them. And
it was like a White House briefing. I was trying to get it all in.
Yeah, very strategic on your part. So I'll try to go quickly just so that others can get their comments into. So from a decompression, what we're really talking about is with the outbreak of the COVID cases within that we're seeing in some skilled nursing facilities, having additional opportunities for individuals to be relocated from the skilled nursing facility to another option, like going home with additional wrap services for them. That's what we mean in regards to some of those comments. Where people are coming from, so they would be coming from either from their home, avoiding a skilled nursing facility stay or an institutional stay, even a hospitalization potentially, right? They would be coming from a skilled nursing facility if they can safely reside in their home. There are still going to be a lot of people who need skilled nursing level of care, right? Or to be in a skilled nursing facility. This will not fit for everyone. It is just a choice along the continuum of services. So from SNFs, and then from hospitals. So from hospitals, a discharge option for individuals to consider as they're making decisions for their loved ones. So that's where they will come from. And data-wise, because we run a lot of 1915C waivers, we actually have quite a bit of data. We're just trying to mine it all to figure out what's the most useful data to look at in regards to this benefit, to narrow it down to our various categories. Other states, we're currently tracking New York, Massachusetts, and a few others that are slipping my mind, but I'm sure my team will friendly remind me of those that we are going to be reaching out to and having conversations on, so we can learn from them what they've done and inform our model. I hope I hit all your questions, and I apologize if I missed one, but we can always wrap back, and you can always send your questions in.
The DD system connection,
JC. Yes, so we are working with the California Department of Developmental Disabilities, DD, on the back end. They're part of our internal work groups to inform our policies as well. Thank you, Kim.
And Marty, I just wanted to thank you also for calling us. You're right, for the decompression, where what we're really talking about is reducing cases and deaths of COVID in nursing homes. And this is just one strategy in that approach. Of course, CDPH is the lead licensing and has much work in process. The operators as well, Craig Cornett is here, have others in process. And I would commend to you a new set of recommendations that came into the state this week from UCSF and an esteemed panel of about 30 geriatric experts. It's posted on the master plan site with about another 30 recommendations, and the secretary was briefed on those this week as well. So there are multiple strategies in place to address the unacceptable level of cases and deaths of COVID in nursing homes.
Thank you. Our next comment will be from Donna Benton. Donna, go ahead and unmute.
Thank you. Thank you so much for the update. We only got to look at it cursory, but one thing I had a question around is how will you bring the unpaid family caregiver into the foreground when they've been right now in the background of anything that I've looked at so far. It just kind of lightly touches on the fact that family members will be, talked to. But one of the things we find, and I don't think this is going to change, is as people go from hospital to home for short-term rehab, it's usually the bulk of that is done by an unpaid family caregiver. And if we don't bring them in sooner, if we don't assess them separately, we have problems. And I don't see that really well articulated in the document, nor do I see any type of collaboration with the current statewide caregiver resource center systems. So how will those be addressed?
Sure, thank you for that feedback. And we can definitely find ways to make sure that that's clear, because caregivers, when there is a caregiver in the home with the individual, it's going to vary depending on what we're looking at, is very critical, both in the assessment of placement. So being upfront during our kind of person-centered assessment, we can make it clear the assessment of the caregiver and the ability for someone to reside safely in the home, and the capacity of that caregiver is going to be really critical. It will also be critical as we are evaluating the individual to reside and continue to reside there in their capacity, because oftentimes it can seem like a good idea, but then become overwhelming for the caregiver and making sure that there are options. One of the things that we have listed in our services is caregiver and family training and resources, and would be happy to engage with people in regards to what that really looks like, what that is, and what's the most valuable way that we can incorporate that into our model. So thank you for your feedback.
Okay, next we've got Jeannie Parker Martin.
Hi, this is Jeannie Parker Martin from Leading Age California, and I just want to thank Stacy and Kim in particular for your great partnership with all of us in asking and integrating feedback after these types of calls. So thank you. And this presentation so far has been really, really helpful to hear kind of the advanced thinking and where we're all going. I want to ask just make two comments and questions. You heard from Anna's great story a while ago when she gave the three comments or three different stories about very different situations of individuals who were in some level of a transition. One of the hopes I think that we all have for a new benefit is that it's less fragmented, and more integrated moving forward. And so although we're dealing with COVID right now, because this is a new provider benefit and it's intended to be long lasting, how will that actually be accomplished, if you know yet, or what are some of your early thoughts on integration and not making this just another option as someone is contemplating either hospital discharge, transition from a nursing home, or prevention from a nursing home admission? So that's one question that I have. And then the other question that came up as you were talking earlier relates to the other provider types. So if I am eligible for the long-term care at home benefit, can I simultaneously receive services on the Medicare or Medi-Cal home health benefit, or on the Medicare or Medi-Cal hospice benefit in California? Because one of the complications, obviously, is somebody may have needs greater than what those two benefits provide in order to receive services at home. And I was a little confused when you were commenting on those earlier. If this is just another option for discharge, how does it make it a little less, how does it make it less complicated, less fragmented? How do they integrate together? So those are my two questions.
Sure. So on the integrated piece, I mean, I think that's one of the things we're really trying to think through, and it's is part of my example. What we're hoping to see is that it is a benefit that is available to Medi-Cal beneficiaries along the continuum. So as their disease state evolves or changes, and as their level of care gets to a point where they need these additional services, then they would be able to get the bundled list of services through the long-term care at home benefit, which is a combination of, medical therapy and HCBS services, whether that's personal care services or other types of services that they would need, but being provided by one kind of provider organization, and not having to piecemeal it together like can happen in many of our environments today. So allowing for a treating physician to say, okay, well, we've been providing you some home health services periodically, but we really think you're evolving in your disease state at a point where you need additional services. You need help with activities of daily living. You need, a variety of other services, maybe medical equipment in the home, whatever it may be. And we're going to put in a referral to your managed care plan to get approved for long-term care at home, right? And then a long-term care at home provider would be able to go and provide. And then it may be at some point that it evolves to a point where now, it's closer to end of life. We're going to put in a referral to hospice. It will transition. In some cases that may not be the complete kind of picture, but I think we're starting to kind of draw those things out so we can think about the warm handoffs that happen naturally in healthcare today as people's diseases evolve and the necessary level of care that's needed. So instead of always only having the skilled nursing facility as an option, which in some cases is someone still may be so acute, or it may not be an environment that's safe for them to be home, that will still be an option for them. There may be other options for families to go home. So I think that's one piece there. On the other provider types, so what we are saying is we've had some initial conversations with CMS. We do have to, as we submit this forward, think about the duplication of services. You may not have had a chance to look at the continuum document yet. We tried to outline for each of them that kind of has a crossover, and I'm sure we've missed one and we'll grab it at some point, but we wanted to be as comprehensive as we could with the time we had, is where there's overlap with this benefit in the services that are provided in the other HCBS services. So someone would not be able to be on hospice and also get long-term care at home because of the duplication of payment, both as a per diem payment, typically with the same services. You can't duplicate there, right? So we will have to think through those. Our team has been doing a lot of thinking about interactions with other services, and feedback from people is helpful for us to think through those intricacies as we develop the policy.
Great. Thank you so much, JC.
Sure.
And I hope the LTSS subcommittee will allow me. I have asked Maria to try to prioritize our invited stakeholders, and this is their meeting here in the queue. So you may be skipped, but I think if all goes well and we're all short to the point, we can hear from everybody. But I think that leaves Brianna Learman next, if I'm not mistaken.
Oh, all right. Thank you. Good afternoon. So seeing that there's 450 something people listening in, let me just introduce myself. I'm Brianna Lamb, the CEO of Local Health Plans of California. So that's a 16 not-for-profit Medi-Cal managed care plans that cover actually about 70% of the managed care beneficiaries, managed care patients. So just briefly, JC, high-level comment and two musings or questions with not really an expectation that it's answerable now, but just placing it on the radar. So high level, you know, many of the local plans are doing some of these services and programs today, even though not a benefit. I think folks are well aware that plans do this through strategic use of reserves or using other resources. So a lot of excitement to turn this into a benefit so we can see it more broadly. And because it's a benefit, lots of dimensions to it, lots of questions, the who, what, where, how, when, pages and pages of questions. No worry, I'm not going to go through all of them. You know, we see that chart and we all get really excited on that continuum of care, like, ooh, it's a roadmap, I can see it, but also it's a reminder that we need a chart to understand the system. And while we really love to have it in front of it, it's also a little disheartening that we need a chart to understand the system, how everything intersects, and anyone would be right to be totally confused about what's going on. So just high level agree with the sentiments of the focus on, I think the phrase is decompression, and talking to the plans in terms about what they're doing today. That seems to be some consensus around that, seems to be a priority and thing that can probably get moved the quickest. When you're looking at existing resources, operations, and services that are out there, at least within the managed care framework, the avoidance of the short-term stays. We see a lot of services and programs, not a lot, we see programs and services out there with a wraparound of the social services and supports. So high-level sentiments, really excited about this benefit, some questions, but focusing on kind of the big framework big framework items. So with that, two questions, observations, which is we're really wondering what we mean by home. And I think a lot of people have that same question. And I did look at the revised paper. I'm not sure it's in there. And maybe it's not, and maybe that's intentional, but just reflecting that I think we're all wondering and recognizing that with this population, there maybe is not an air quotes home, or maybe it's a different place. So just reflecting that. And then the other piece too is so many of the questions and answers we have do depend on what the populations are. And so just really looking forward to identifying a little bit more which populations are served, because as you know, and I'm sure many of the listeners know, managed care is, you know, fortunate or unfortunately, long-term care is not covered or carved in all of managed care. That's something CalAIM was going to be accomplishing. So there are some nuances there that could be addressed when we're identifying the population. So those two kind of observations, last questions, and I think that's it. And just thank you for this concept, and we're excited to work with you on it.
Thanks, Brianna. And we look forward to working with the managed care plans, or continue to working with you guys in regards to especially all the experience with especially our CCI plans, who have been doing a lot of this great work for a long time. And so hopefully we can leverage all of that great experience. On the home, it is intentionally still a little vague right now. We are looking at a lot of things. It is complicated, as you would imagine when you see that chart. We want to make sure that we are being thoughtful about this. And as I mentioned in some of my opening comments, we are really thinking through some of the services, whether it's in RCFEs and our assisted living, et cetera. And so I think we're still thinking through that. So it is intentionally vague at this time. In fact, there is actually a note in there that says it's completely out for this version, but we are continuing to look at that and expand and think about that. We've gotten a lot of letters with that included, and thinking broadly about what is the definition of home on that part. When it comes to the populations, it wasn't primed for this version, but we will be giving some more meat on the bones when it comes to eligibility and populations. And so what I would say is look forward to engaging with people on that in the future, and we will be putting a little bit more detailed there, other than the high level buckets that we have right now of just skilled nursing level of care, right? That's, you know, pretty common for most of us, but we need a little bit more context around that. And we will have to have that for the submission to CMS as well. And then just to point on your piece with CalAIM, we are also thinking about that. As many of you know, a lot of the components in this proposal were covered under CalAIM. And so with a combination of both enhanced care management and the in lieu of services suites for HCBS services. So we're thinking through that interaction of what that looks like and how we can leverage some of that work that's already been done. And that will be in future iterations and versions to come as well. So thank you.
Thank you. And next we have Kim Lewis.
Unmute myself. Hi, Kim Lewis from the National Health Law Program. I want to thank DHCS, Will and JC, as well as Department of Aging, Kim McCoy-Wade, for the invitation and for having this conversation. I think it's really important. And I really want to kind of underscore some of the comments I think made earlier by the subcommittee on long-term services and supports around not having a model be too medical in sort of form and nature. I think a lot of what we see when we do a more medical model is a more narrow kind of focus on needs than will actually meet people's full holistic needs in terms of serving them in the community and also meeting their social needs for housing and supports and other things that, whether they're covered under this benefit or not, are going to be critical for their success. So I'm going to look forward to seeing the proposal from you all at the end of the month. A couple of things I wanted to just make observations about. One is the 1959 benefit is broader than the 1915C waivers, and that it offers states, I think, opportunities in two respects that we should be thinking about for this benefit. One is that it doesn't limit the population, right? A target population, as I think JC said earlier, where you might have a very narrow group that you're serving, whether it's kids with high-end medical needs or other populations, and then building a wait list around it and also being very kind of narrow in the scope and focus of the program. So that's both, I think, an opportunity as well as a challenge, because then the state has to really think about who is the target of this service, and not everybody's needs are the same. I mean, people with behavioral health needs, kids, with more high-end special medical needs, people with developmental disabilities, they're all very different. And so if we're going to try to open this benefit up statewide, which I think into all populations, which is important, we really need to tailor those services to meet the needs of the particular individuals and not be too cookie cutter about this. So that's going to be a challenge, I think, in terms of kind of making it broadly available, but also trying to make it relevant for individuals and be individually driven. I think the other thing that's an opportunity is the state plan amendment also means that you don't have to meet the institutional criteria to get the benefit. And I think that's something we need to have. It isn't a focus of this conversation, but it really, I think, should be, in order to avoid institutionalization. We might want to be serving people before they get to the institutional level rather than pushing them down the road. And then now they need an institution, and now we're going to serve them at home. I think the I waiver gives us, or the SPA gives us an opportunity to broaden that. And I think that's the purpose of it, so that it isn't just when you meet institutional criteria. So I think we have to look at that and think about how we can maybe build a little bit backwards from the front door of like the nursing facility or an institutional placement, since you're not going to focus on other kind of community settings like intermediate care facilities. Those are all obviously places and populations that could be served by the I waiver. I think it is something that needs to be thought through. And then in terms of the assessment versus eligibility, I saw information in the new proposal today about assessments, but there really was no talk about eligibility. And I feel like you've collapsed these things as if they're one. Having an assessment of individual needs is not the same as determining eligibility for the program, which is going to be a very important kind of front door decision. And that's going to be about, who gets in and who doesn't get in when you have a limited benefit or it's limitedly available. And so that's critical. And I think that's probably something that needs to be really thought through here. And then finally, I think you just touched on this, JC, a little bit, but the intensive care or care coordination aspects of this, not just on the medical needs, but on the social needs and other things that might be either the managed care plan's responsibility or some social service agency's responsibility, or the Medicaid managed care, the specialty mental health plan's responsibility if they need behavioral health services. You've got to figure out how to coordinate those systems that are going to need, that are carved out from this benefit or may not even be kind of integrated into this model, and how are those services going to be coordinated with this? So not just IHSS, but other systems, you know, where the needs are going to be there. And so it feels like that's a critical piece. And I think I'm glad you're thinking about enhanced care coordination, because it's a lot of time and energy spent on the CalAIM proposal to try to really put together a broad model about care coordination that the health plans were going to take on and think about, and that perhaps even give up to another carved out system like the regional center or especially mental health system, when they might be more appropriate to be the home for that person. So I think those are all things to think through, and I'm excited about this benefit, but also want to think through, you know, how do we be successful in making this work and actually serving the individual needs and the families that we're targeting. Thanks.
Thanks, Kim. I won't necessarily respond to all the different pieces, but I think they are all really important in why you probably haven't seen us come out with eligibility and or our defined target population yet, because other than the very high level pieces in the proposal, because it's really complex, and because it's statewide, and because it is outside of just the institutional level of care, which is most of our 1915C waivers, right, because of the requirement there. And so we are trying to be very thoughtful, and any thoughts or feedback that people have, you know, it is something that people have generally submitted comments to us that, well, we want more information about this item. But I think we would also say, as we continue to engage people, especially with ad hoc, what is the need? Even if we have to have it smaller to start and we can't, and the benefit has to evolve over time, I think we would like to hear from people. What are the most pressing needs? It does give you the flexibility on the eye of being outside of just the institutional level of care. And so what does that look like from an overall utilization management point of view for the state, to make sure that we continue to be prudent with our dollars, but also making sure that we are avoiding, because I do think it is one of the biggest advantages to avoid institutionalization and people going into that level of care. And so when and if possible. And so thank you for your thoughtful comments.
I'm just going to point out that we have about 10 members of invited stakeholders who would like to make comments. So I'm going to ask everyone, just as I will in public comment in a few minutes, to try to have the exchange be about 2 minutes. So I know it's tough, but we do want to hear from a lot of voices. So I believe Denise Leiker, you're next.
Hi, thank you so much for inviting me to participate today. I'm Denise Leiker. I am with Independence at Home at Scan Health Plan in Los Angeles County, where we have an MSSP program, CCT program, and I'm also a part of the MSSP Site Association. So I have 2 questions. My first one is probably the real easy one, is are we still targeted to have all of this wrapped up and launched by January? Because as we're hearing today in this conversation, there's so many more questions than there are answers, and this is great conversation. So question number 1 is timeline, because I know you guys are hoping to wrap up this month and then be writing for CMS and that type of stuff. So that's question number 1. Question number 2, looking at the vignettes today, and this may be a little duplicate, but that's because this is still unclear to me. These vignettes, I could easily map out the programs that MSSP would have managed that case and coordinated everything and handled it, CBAS, PACE, CCT, all of them in those vignettes on the page, and that already do the coordination. And I heard you a few minutes ago talk about this new benefit would be bringing everything under one roof, but person-centered care is so complex. Finding one provider that does everything, bio, psycho, social, mental health, housing, everything, all of that stuff together is really hard. So I'm going to pose the question differently than what's been in the conversation. Set aside the funding streams, the C's, the I's, and everything. How is LTC at Home different than anything on this page? Like, what gap is that filling that we don't already have in the infrastructure? That would help me in order to be able to really structure some feedback, because we have so much competency on that page and so years and years of expertise to do this type of work of coordination and helping people be successful at where they need to be in the community. What's different about this?
Sure, a good question. So the question about January is unlikely, right? So I think we are realistic in that manner. In fact, I never say January. I always say early 2021, because I have learned over time to not give hard dates. We rarely meet them. So we use seasons at DHCS. So that's the answer for that one. I think what I would say there is we're committed to engaging while keeping the momentum, but continuing to engage with people to get the policy right. On your second question, I really think it comes down to a number of factors. I do think we want to see even if it takes time, we want to see a higher level of coordination for these services. One of the biggest feedback we get from people in our 1915C, and I hate to throw the C's and I's out there, but beneficiaries in those programs, is how even when they have a case manager or a care coordinator, how complicated it is. So many different people that they're working with to make it happen, and how complicated it is. The thing we get feedback on is the barriers, the issues, the concerns, right? And that's not across the board, because there are some amazing pieces. So it's not carte blanche. So that is a goal of ours. It is a desired goal to kind of, one, have something that's actually a state plan benefit that's just embedded into the system with a physician's referral. That is not how it works in RCs, right? There's more hoops you have to go through from an enrollment and federal requirements, et cetera. We like the flexibility of the I. We like the idea of a statewide benefit. A lot of the programs you mentioned are statewide. Now, this will take time to get statewide too, but we think there may be a little bit more capacity by tapping into all those existing very seasoned providers you just mentioned, and tapping into those existing resources to leverage this and maybe get it statewide. But that's where we still need a lot of work. So those are some immediate ones to kind of highlight that we are looking for. And looking at, but we know we need to leverage and lean on our experienced providers in order to make this work, and still a lot of work to be done on those fronts.
Yeah, Denise, I would just further add, it's really trying to take the master plan, this subcommittee's recommendation of a statewide core set of services. So it's taking the services that are so high quality, but the access and the coordination are such a challenge. And if we can break through the access and coordination issues and build on those models all over the state, that's that perfect mix we're trying to get. And it is complex, but we try to make it simpler on the other side, hence more time. Should we move to Pat?
Yes, thank you. And thanks for including me in the conversation. I'm Pat Blaisdell with the California Hospital Association, and I support our post-acute care providers as well as hospital case managers that are involved in care transitions. I want to add to the conversation, align myself with the comments of my colleagues prior to this. One of the things that I would encourage the group to think about is how care transitions, care coordination, and the services that are provided through this benefit or any other are inextricably interconnected. I am a bit struck by and I haven't had a chance to go through the whole design document that came out earlier today, but the transition services are kind of defined as something separate from the care coordination services. And in fact, I think we don't really address the issues as clearly as we need to. If we think of care transitions as just one point in time with a start point and end point, that really doesn't address the needs of the individuals that we're serving. More often than not, a plan can be set up, and a very thoughtful one can be set up and be fine for a few days, but also may not be, it may need to be changed, it may need to be tweaked, especially as the needs of our individual beneficiaries change. When they're coming home from the hospital, what they need at the beginning is different than what they might need a month down the line. As people get older and have chronic conditions, their condition may in fact decline, and they may have greater functional needs. And the distinction or the fragmentation, well, I don't want to call it fragmentation yet, but I'm concerned that if we define care transition services as kind of a separate one-time service that's accessed differently than the care coordination services, that may not allow us to identify those things that may help a person stay in the home and negate the need for that transition. So I just encourage the group to think about how care transition and care coordination shouldn't be a one point in time thing, that it is something that needs to be happening on an ongoing and longitudinal basis.
Hi, Pat. Thank you for that comment. So we'll look at the write-up to see why it's maybe coming off that way, because I don't think that that's the intent of the transition benefit. Just to kind of highlight what we're talking about transitions there is not just like a transition that's happening. It's our more kind of standard, what we call transition and support services, where someone's finding the placement, where they are doing the home modifications when they get there. Not that there wouldn't necessarily be a need for home modifications in the future too, your point well taken. So we'll figure out how to make sure that's addressed in the write-up. I think what we were trying to make sure was clear was some people thought that the transition cost would be a part of the per diem long-term care at home cost. And that's not feasible. Many of the people on this call who know how to do transition services is it can be quite costly to identify the placement, to do all the coordination that takes with a transition service, to get the home modifications done in the home, whether it's a ramp or a bar in the house or whatever it is. It can be costly. And so we needed that to be separate, not that it's not coordinated. So we can make sure that that's clear in the document, kind of the transition there, and coordination would be across both. And so we can look at that. We don't want that to get lost. We may have gone too far trying to distinguish the two so that the payment mechanism would be clear that once someone's in the home, it should be a per diem payment for the ongoing kind of medical and home and community-based services with coordination tied to that, but separate the very complex transition and support services to get someone moved into their home safely is pretty unique and requires unique providers who do that well and can sometimes be costly. And so we were trying to separate those two. So we'll look at our write-up to see how we can make that clear.
Great, and I think next we've got Kristen. I'm sorry, Christine Heyman.
Hi, good afternoon. Hi, this is Kristen Heyman. I'm the Executive Director of the California Association for Adult Day Services. I just wanted to say thanks so very much to Kim and JC for the invitation to participate in today's LTSS subcommittee and for the opportunity to just provide you with a couple comments on the new proposed benefit. My colleague Denise Leichert addressed the questions that I was going to ask, so I'm really just going to provide just a couple comments. And I also wanted to thank the subcommittee for the revised paper that they offered to the state for review. So just for context for those of you on the call, Adult Day Healthcare and CBAS Community-Based Adult Services Program is a Medi-Cal managed care benefit that's delivered by licensed and certified providers, and it provides a cost-effective community-based alternative to placement in skilled nursing facilities. And as Denise pointed out just a couple speakers ago, CBAS and MSSP are two very effective LTSS program models that have a very deep expertise in helping individuals defer and avoid institutional placement. And each program represents over 40 years of expertise in the community-based to skilled nursing placement. We certainly agree with our colleagues and support the committee's request to more a measured approach to this proposal to create a new benefit. We certainly agree, and as our colleagues, that we continue to lean in programs, the years of experience providing care in the community, and we certainly want to be very thoughtful on how we can serve California over the long term rather than rushing this process. So just at the outset of the coronavirus pandemic, the governor deemed adult day healthcare CBAS as an essential service that protects those who are most at risk from COVID-19 due to their age or any underlying health conditions. And over the past 4 months, we've been able to protect over 37,000 individuals at home by providing them with the essential care and direct support that they need. And we've been providing these services in the community that exist with exactly what this proposed program seeks to do, to decompress and actually avoid skilled nursing facility placement. So we certainly recognize that the COVID-19 pandemic has increased the urgency in this concern about our state's nursing facilities during this crisis. And we are ready to assist with the development of a realistic and meaningful benefit that could assist in this respect if it builds upon and enhances the currently established programs that have paved the way in preventing hospitalizations and long-term nursing home stays. So just wanted to say thank you for your time and appreciate it. appreciate all that you've been doing. Thank you.
Thank you so much. We've got about 5 more invited stakeholders we'd like to hear from. So I'm going to ask you for a minute, and we'll try to keep our responses as tight as possible as well. We're trying to hear from Dean, Karen, Ann, Paula, and Linda. I also want to acknowledge that Supervisor Barger's representative has joined us, Monica Bankin, and we're also joined by June Simmons as well. With that, Dean.
Hi, everybody. I'm Dean Chalias. I'm the President and CEO of the California Association for Health Services at Home, serving the home health and hospice agency providers around the state. We're very supportive, obviously, by definition, of care provided in the home, which is exactly what a large number of our members do every day across California, and that's provide home health and hospice services to Medi-Cal beneficiaries. So we're excited about participating in this program. We look forward to working with all of you on whatever the certification criteria may be and however else we can be supportive. Thank you.
Thank you, Dean.
Dr. Lincoln?
Yes, hi everyone. I am Karen Lincoln, Associate Professor at University of Southern California. I'm on the research subcommittee as part of the MPA, as well as a couple of other committees. My comment is in regards to the beautifully written statement, and the one word that I would like for you all to consider including in the statement, and that is quality. Because I'm also on the equity work group and my research focuses on health disparities, particularly among African Americans, I think it's really important to address the issue of equity. And that is, you know, having a benefit is definitely something that I would support, and I think we all support that. But, you know, we have to also consider the quality of care, which is very poor for many African Americans and low income older adults. And so in terms of measures and assessments, I think it's really important to think about, you know, nursing homes and certain resources in low income neighborhoods more likely to close. People being moved because nursing homes are closed, people not having access, unequal treatment that actually happens in nursing homes, and longer term placements in nursing homes as a result of poor care and poor outcomes. And then of course, the higher level of need that's required once people, you know, are discharged just because of what actually happens in some of these nursing homes. And so I think, you know, attending to increasing access, but also it's very important to consider making sure that these resources that are available to some of these underserved communities have a higher quality, and that is also going to conflict with the demand on the healthcare and particularly aging workforce, right? And so I think in terms of who's going to be providing this care, the quality of care, these are things that really need to be taken into account when we're addressing issues of equity.
Thank you very much.
Anne?
Hi, everyone. I'm Ann Kinderman. I'm a palliative care physician, direct the palliative care service at San Francisco General, and pleased to be part of this group. So I had just a couple of comments or question. I noticed one of the significant difference between the first draft of that I saw just the beginning of the week and the draft that I saw just today, in that this most current draft explicitly excludes people who live in RCFEs and RCFCIs from this benefit. And I've heard that there's, you know, some conversation around this, but I just wanted to voice that I think that would be missing a pretty big population who might really benefit from these services. And so just want to be a voice to say, I'm hoping that that's not set in stone and that could still be considered, recognizing that people can't have two 1915 programs. So the assisted living waiver, they can do that in this program, but that doesn't what about the people who aren't using that waiver, who might really benefit from this program? So that's one point. Another point, just building off of what Dr. Lincoln just mentioned, I will just say as a predominantly a clinician working in San Francisco right now, that during the pandemic, since we're talking about this to decompress skilled nursing facilities, there's been a big problem in terms of people getting reliable home care during the pandemic because of PPE access and just these agencies and their own staff and their concerns about their safety, or the patient's concerns around having outsiders come in that are healthcare providers who might make them sick. So just if we're using this as a mechanism to try to get people out of high risk environments, then how are we going to ensure that they are actually going to get reliable services in the home? And then the last point that I would say just for consideration overall, as I think was mentioned with a chart, which is amazing, but I will just confess that, you know, like I said, I'm a practicing clinician, and keeping track of all of these benefits is hard enough for me. So trying to imagine someone who's vulnerable, trying to weigh the benefits of different programs and enrolling in which one, what is going to be the support, and who are the people who are going to make sure that there are good people out there who know all of these options and can really try to counsel people who aren't healthcare professionals or social service professionals in making these hard choices.
Thank you, Ann. And I think the only thing I would just say there is your last point emphasizes exactly what we think is pretty unique about potentially the future of long-term care, the potential opportunity with long-term care, because of that exact complication, especially navigating some of those other programs. Not all of them can be very challenging. And so, so we agree with you. It's one of the guiding principles we have for this one as we continue to design the policy around it to reduce some of that complexity.
Thank you. We're going to jump to Kathleen. Kathleen Kelly, you're next.
Thank you. Yeah, I'm Kathleen Kelly. I'm Executive Director of Family Caregiver Alliance in the National Center on Caregiving, and thank you very much for the opportunity to participate this afternoon. I just have two quick comments that I'd like to make, both around family caregivers and the role of assessment. And the first one is that I love the vignettes. I think because there's such a broad spectrum of you know, situations within families and persons needing this type of assistance, it's always helpful to have a vignette that really tells the story, and we can vet the services to the story and see how they might work for each kind of condition. But I have to say there was no story that really concerned the families that we have been dealing with for like 4 decades, which is those persons carrying with a cognitive impairment, most likely dementia related, which does, you know, make a difference in the terms of your approach and the services and so on, description. So that was one thing that I think, you know, the issue around cognitive impairment and, you know, people who may not actually be able to self-direct as many others might be able to is a confounding factor. The other issue is around the role of family members. I just want to amplify a bit on what Donna Benton had said earlier. And that is, in 2014, there was a rule change within the 1959 waivers that the plan of care, you know, rests on the presence of unpaid support in the home, most likely provided by family and friends, that there is an assessment of those involved their own care needs. And this rule, you know, stood. In our work of looking around reviewing the waivers for HCBS services, you know, writ large, home and community-based services, mostly IHSS or in-home support services waiver, that we found, you know, few states really, you know, do an evaluation or assessment of the family caregiver, and less than 20 and even less than 10 had any sort of robust approach, mostly using those uniform caregiver assessments that were used in other programs in the state to fill in, you know, the blanks on the kind of caregiver needs that might be there. But the one thing I did want to emphasize, and I sort of feel silly about stating this, but the issue around assessment has to go beyond the willing and able question. And the questions need to be directed to the family caregiver and not the person who's needing assistance. And so this was such a basic thing that I felt like I needed to point it out in the report. But those are the issues before us, because some people will go back to a living situation for which there is no support in the home, but very many of these individuals that you're just talking about will go home to family members, and their needs, particularly at that stage of impairment, really need to be assessed for their own needs beyond whether or not they're going to be available to provide that kind of a level of care. Thank you very much.
Pauline?
Hi, my name is Pauline Chitara. I'm the Deputy Director of California Advocates for Nursing Home Reform, and I appreciate the opportunity to comment and work with you all. We have a 1-800 hotline, and we receive calls from all over California from consumers from a range of issues, nursing home discrimination, when they're trying to get in on Medi-Cal, and sometimes as the skilled nursing facility wants to get rid of undesirable residents, we will see staff refer people to transition services. So we wanted to know what will be done to ensure that facilities aren't using this to discriminate against residents, that the referrals are made by the requests are being made by the residents or their representatives, and not just by facilities looking to get rid of residents. And of course, we do know we get many calls from people who want to leave facilities and want to get care at home. But the other issue is the share of cost when they go home. So one of the questions we have is, will spousal impoverishment apply for this program? And also, can rent be used as a deduction like it would be, for example, in the board and care deduction, because many people are unable to access Medi-Cal because of the high share of cost. They're unable to afford the services and their other household needs. Thank you.
Thank you. 2 more comments and then we'll go to public comment, but Linda Nguyen?
Good afternoon, Linda Way with Western Center on Law and Poverty. Thanks for the invitation to participate as well as the conversation, as the new benefit provides some opportunity to build upon rather than replace existing services. I share the question around the care coordination across the different programs that already provide a continuum of care services, and want to echo the need to center the benefit around equity and ask what is being done to ensure that this new benefit provides high quality care to California's diverse communities, particularly in light of the disproportionate impact of COVID.
Thank you, Linda. And I believe our last comment will be from Ricardo Torres.
Thank you very much. I want to kind of underscore both Kathleen and Donna's points in terms of working with families and the home environments. I'm Ricardo Torres. I'm board member of the Native American Health Center in Sacramento. Going to make just a couple of comments, keep it as short as possible. My concern also is related to the standard of statewide care. We saw that certainly with COVID. The disproportionate explosions in rural and remote areas concerns me, and I think we need to take that into consideration when we look at the services we want to ensure for our populations. And this program that we're talking about, when we saw like Kern County and in the Imperial Valley, et cetera, those places that are remote don't have the same kind of quality and access to services that some of the other counties do. That's just in general, but it impacts people of color very specifically. All right. At the same point, remote and rural areas is also where the government has placed many of the Native American populations, and we then don't have those same access that you find. For example, live on the Hupa Reservation, you drive over an hour to Eureka to go to your hospital. So even though they might have a small clinic on the reservation, they don't have the same access to care that many of the other populations have. So I would like you to consider working with tribal governments and the tribal FQHCs in California and see them as partners in this venture, because we customarily, we work on a daily basis with all these entities and can ensure the access to our populations. And we are thankful that you've included us in this conversation. Thank you very much.
Thank you so much. It was wonderful to hear from so many new voices at this table, but not new to this conversation. So thank you so much. Before we do turn to public comment, I wanted to come back to the subcommittee first. Catherine or Anna, to see if there were any things you wanted to pick up. There were many members of the subcommittee whose hands were up. Peter, Jeff, Maya, many others who we ran out of time to call on. So I apologize for that and know we have other forums. And then of course, JC, if you want to say anything before we open for public comment. But Catherine and Anna, any committee reflections?
I think the conversation is rich, and I appreciate everything people have brought to the conversation, and I think we have an obligation to think about it and figure out how to incorporate the good thinking.
Yeah, and I'll just add, thank you everyone for your comments. It's really important to hear the different perspectives, and we'll definitely be taking your points back as part of our conversation as we move forward. So thank you all.
The only thing I would add, Kim, is that for those of you who weren't able to speak today, if you want to submit your comments, we have our inbox on
next slide.
Benefit design. Oh, perfect. Go for it then.
We're totally in sync. You said
I had to do the plug, but go for it.
Exactly. We do have 388 attendees on the line right now. And so I don't think we'll be able to hear from all of them in the next few minutes. But we do, we read the letters. We have had wonderful, thoughtful letters in the last few weeks, and we absolutely read the emails. For this project, you see the email on the slide right there, ltc@home@dhcs.ca.gov. You're also welcome to email engage@aging.ca.gov for the master plan, and we are closely coordinating on making sure that both of us have that input in all directions. So we heard from, I believe my team said hundreds of folks after the last meeting, and we welcome that again this time. Without further ado, Maria, can you lead us through how the public comment is going to work?
Sure. So public comments, if you are joining on your computer, you always have the option to use the raise hand icon to get into the queue. Looks like we have quite a few folks who have had their hands raised for a while. If you are joining by phone, you'll want to hit *9, and that will sort of raise your hand in our virtual platform. And we'll start off with Jeffrey, who's been very patiently waiting to be called on. Jeffrey, go ahead.
Okay, sorry. I'll be very
are.
quick. I'll be very quick since I have other ways of saying it. The only point I want to make, other than thank you for the opportunity to have this discussion and for the updated proposal, is that one group of providers that has not really been engaged in this discussion are the entities that provide specialized services to people who are blind or who have low vision. These providers, most of whom are specialized agencies for people with vision loss, but some of whom are independent living centers like Freed, provide essential services that make the difference between many people with vision loss being able to remain in their own homes and avoid institutionalization. Thank you very much.
Thank you, Jeff Tom. And I actually think we're now going to go to another Jeffrey Tartagia.
Yes, I'm Jeff Tartagia, and an advocate. And again, my reminder is physically the clients, but to Kim and to, can you give me a better understanding of why California is changing the waiver from the 1915C to the 1915I, and what happened between C and I that you had to go that far for the state of California?
I don't know when you're going to see me again.
I think, Jeffrey, we're going to take that question back, because one of the things we've heard loud and clear is that we need to communicate more information. Maria, can you mute everybody else, please?
Yeah.
Right at the end of it, I'll come and talk to you. It'll be done.
Oops, Kim, you're muted now. She muted everyone.
We are going to, we heard this feedback to have more communications that have more information, more background. I too have I love the chart, have a challenge with the chart. So we will take that back as part of our renewed commitment to more communications and clearer communications. Let's keep moving through the queue. Debbie Toth.
Hi, everybody. Can you hear me all right?
Yes.
Yay. All right. Thank you so much. Quickly, you know, I expressed this on a call we had on Tuesday. I'm very concerned that we're spending so much human and brain power and energy on creating a new benefit when we have people who are dying by the thousands in skilled nursing facilities and residential care facilities with historical substandard levels of care. And we have this disproportionately impacting elders, people of color, and women who are working in these facilities. And we have existing programs and infrastructure. We should be focusing our energy and effort on upstanding, lifting up, and expanding right now. That's a concern. Moving forward, assuming that this is, yes, indeed, we want to do things statewide. We want more coordination. We want richer benefits. We want more options for people. I'm just curious why we're so silent when we talk about appropriate organizations that could be providing this, that we don't include CBAS, MSSP, and CCT, the experts who are doing this work already. Those are my comments. Thank you.
Thank you. Bill Pelter.
Hello. Thank you. A great presentation today. Two things that come to mind. As great as the benefit is, I would like to hear a little bit on the supply end. Arguably, the benefit is the demand end. One of the issues we have in the San Francisco Bay Area is that due to the high cost of living, we have a growing shortage of paid caregivers because they cannot afford to do the work at the wages that are offered. A second piece is, and this happened in my family with my father when he was still alive, is that the caregiver, as pointed out in Home Alone Revisited, the AARP report, the family caregiver is dealing with much more significant and complex health issues unpaid in the home environment. And that simply asking somebody, and I'm thinking about my mom right now, asking her if she's ready and willing and able to take care of my dad, she's going to say yes, when in fact she's not physically capable of doing that. And so we need to have some safeguards here. And I'll just end on this point. On the area plan that is going out of date in Alameda County, it was noted that 10% of the family caregivers are over the age of 80. And so even if they're doing very basic caregiving, they are at risk. And in a county where Alameda County rightfully celebrates their fall prevention program, I don't see that those two notions are compatible. So again, if I could hear just a little bit about what I've mentioned, I'd appreciate it. Thank you for all the work you're doing.
Yes, clearly more to do on the family caregiver side. I think we've heard that loud and clear. So again, there'll be more coming. Let's get a couple more voices in the room. Nancy Volpert.
Sorry. Hello. Now, first, thank you all for pulling this together. Listening to so many of my colleagues and friends from the state, it's really inspiring to hear the conversation. Debbie Toth said much of what I was thinking, so I will just say ditto what she said, because I do think one of the questions that JC has referred to a couple times is about how this will expand access. And it's still not clear to me how this plan would help increase the reach of this program into rural areas and other areas that are already currently underserved, and how this solves that problem. The other question I have is just a comment on the updated draft refers to there are other resources for funds for rental assistance and housing transition. And I think if you look at the conversations around housing and homelessness in the state, it's pretty clear that that's not sufficient currently and has built-in racial inequities. And so I would urge you as you go to your next version to revisit and reconsider that perspective. Thank you so much.
Thank you. Greg Thompson.
Greg, your line is open, but you might have to unmute.
Sorry. Hi, thank you for the opportunity, Kim, and I'm glad your Director Lightborn's back. I just want to echo what the last comment was. I'm really confused on the goals of this. It seems like it's an immediate crisis response that we need. And when I heard 2021 is the goal, that seems like 6 months from now, a lot of people can potentially die from this. And I'm no expert on waivers or state plan amendments, but my question is this the only way we can do it? It seems like you're trying to accomplish two things. One, solve the immediate crisis, and two, create an excellent, long-term supportive program. So that was my question and comment. And thank you to all the stakeholder and committee members.
Thank you. Eleanor Clausen.
Eleanor, your line is open, but you might have to unmute. Should we swing back around, Kim?
Sounds good. Mary Sheridan.
Hi, thank you very much. A lot of what I was going to say has already been said, so I just want to add on to the tail end of it that I'm the director of the Association of California Caregiver Resource Centers, and we have 40 years of experience doing assessments of family caregivers and supporting their needs. And I just want to offer us up as an organization that's experienced to add to the conversation as you go forward. And thank you very much.
Thank you. Amanda Stillers.
Oh, there we go. First of all, I just wanted to thank Department of Healthcare Services so much for, and everybody else who's been working on this so much for recognizing, getting people out of the nursing home and preventing them from going into the nursing home I'm a licensed clinical social worker. I've worked in adult day healthcare for the past almost 25 years. Prior to that, I worked in hospice, home health, acute care hospitals, and of course in nursing home as a social worker. And the reason I got into adult day healthcare, which is now CBAS, is exactly for the reason that you guys are, or we all are working towards the long-term care at home ideal, which is keeping people out of the nursing homes and helping the people transition out. One of the reasons why I love adult day and why I stayed in this industry when I found it was because of my experience in working in a nursing home as a social worker. When I read the regs in the very beginning, it was that adult day healthcare truly was nursing home care during the day where people could go home. So I deeply appreciate that you've added us into your new document as one of the potential providers of these services. It's what we do best. It's what is our guiding principle. So I deeply appreciate that. The one thing I wanted to talk about it, or maybe just quickly mention, because I know we're tight, is my goal would be, or my hope would be, is that this program would potentially be a short-term program. So people might need it for quick acute services, but after they're able to receive services, say in a CBAS center or back in the community, that is kind of the goal of the program. Some people, of course, would not be able to do it. If they go from the nursing home out into nursing home at home, but hopefully go back out into the community, into a CBAS center where the services would be less expensive, more cost saving, and they'd also get all the services that CBAS and say MSSP together could provide, with the socialization, keeping down isolation, supporting the caregivers with respite care, and all the other gorgeous things that adult day healthcare and CBAS programs provide. So that would kind of be my thought on it too, is to look at a discharge plan and have that as one of the commitments of the program, that people actually can get out of it. and allow us to continue to provide the services in the home as CBAS services in the home, which we're currently doing now. Thank you, guys.
And then if we can circle back and see if we can get Eleanor Clausen.
Just wanted to say thank you for this meeting. I don't really have a question right now, but I really appreciate all the feedback that we heard from this meeting.
Thank you. And I see that we are at time, so I just want to reflect back thank you to the still 300 plus, almost 400 people who are with us on a Friday afternoon. Here are the next steps that CDA and DHCS are taking back. First, we're going to post the wonderful documents from the LTSS subcommittee, the stories that Anna Octon shared, and the statement that Catherine Blakemore shared. Thank you. Second, we'll be working on version 4 or 5, depending on how you count, of the design document, taking in all this wonderful feedback, covering so many issues, both broadly and deeply. Third, there'll be some updates on the stakeholder process. We hear you about the need to spend more time together, so we're working on that as well. So stakeholder process update coming. And I think we're also thinking about, fourth, other communications that would be helpful to have more background, speak to different audiences, talk about the other COVID-19 responses. There are many other COVID responses in SNFs that we can put this in context. So more communication coming. And then of course, fifth, ongoing communication is welcome. Small meetings, emails, letters, dialogue with the legislature, all is expected and deeply appreciated as we chart this new path together. With that, let me see if JC or DHCS has anything to say.
No, just thank you so much for everyone's engagement on this today, and we continue to look forward to work with you in the future.
Thank you all. Stay safe and stay connected.